Good morning, and thank you for joining us for Medicaid Modernization Part 2, Key Considerations for Public Health Contracting. This is part 2 in a 4-part series organized by the Iowa Public Health Association in partnership with the Iowa Counties Public Health Association in consultation with colleagues at the Network for Public Health Law. My name is Janine Moody, and I serve as the Executive Director of the Iowa Public Health Association. It's my privilege to moderate this morning's session. A few housekeeping tips before we begin. Due to the number of attendees on this webinar, all participant lines will be muted. To submit a question for our presenters, please use the questions feature in your GoToWebinar control panel. I will monitor all submitted questions and pose them to our presenter during the question and answer portion of the webinar. Today's webinar will be recorded and posted along with presenter slides to the IPHA website. A few technical tips for optimizing your webinar experience. 1, utilize a headset. 2, use a wired connection versus wireless if possible. And 3, close any applications on your computer which require large bandwidth. Now let's meet our presenter. Susan Freed is a senior shareholder at the Davis Brown Law Firm, where she practices in the areas of health law and employee benefits. She is the former chair of both the firm's business division and the health law department. She practices in the firm's Des Moines office. In her health law practice, Susan represents a wide variety of healthcare providers, including physicians, hospitals, long-term care facilities, ambulatory surgery centers, and county facilities, with respect to transactional, reimbursement, and regulatory issues. She drafts contracts, employment agreements, physician recruitment agreements, corporate documents, and corporate policies. In addition, she counsels clients on various health law issues, including healthcare reform, fraud, and abuse, Medicare and Medicaid reimbursement, EMTALA, managed care contracts, and confidentiality laws. Susan authors the Davis Brown Healthcare Reform blog, in which she provides up-to-date information about healthcare reform, including updates on the federal government's implementation of the Affordable Care Act, new regulations, recently issued guidance and enforcement updates, as well as issues specific to the state of Iowa. We're so pleased to have you with us this morning, Susan, and I will now turn the webinar over to you.
Great. Thank you, Janine.
Here we go. We should see your slides in a second. Great. You're set. Thank you.
Okay. Thank you. All right. So I'm going to start by just going over some preliminary items relating to these managed care contracts and things that you should just keep in mind as you're reviewing those. First, we've heard a lot of confusion in the provider community about the status of the provider agreements, when they're required to sign. Some managed care contractors came out and specifically requested that providers submit their signed agreements back by, I believe, September 14th, September 15th. Obviously, that date has come and gone. So we've gotten lots of questions from providers about, you know, what's the status of these contracts? Should I be signing now? Is there any opportunity to make changes? You know, we're getting a lot of pressure from the MCOs to sign these, yet we're hearing from the state that these contracts haven't been approved by them and they have yet to be reviewed. And so we do believe it's a false statement if you're hearing from the MCOs that these provider agreements have been approved, and some of them were telling people that in September, indicating that, you know, because they were submitted with the RFP, they'd been approved. But that is false, and IME came out and publicly said that last week. These agreements, while they were submitted with the RFP, and one would hope that they were preliminarily reviewed at that time by the state, they haven't been formally approved, and so there could still be changes to those. So we don't believe there's any rush for you to sign these. We would encourage you to closely review them, to ask for changes before you sign them. We also don't believe that it's true that the managed care companies can't make any changes to these. We have seen some, you know, agree to make some changes that have been requested when we reviewed and asked for changes. And so we would definitely encourage you not to rush into signing the managed care contracts yet, to take your time in reviewing them, to ask questions, to make sure you fully understand what you're agreeing to. And we're going to go through today what I think are the key things for you to keep in mind, where I would suggest that you push back in some of the contracts, provisions that I think it's just really important that you're comfortable with and really understand before you actually sign on the dotted line. okay? And some of you may be wondering, well, if the state hasn't approved these and the state could require changes, why are the managed care contractors pressuring me to sign? And that probably is because once you sign, all of the agreements state that the MCO is allowed to unilaterally amend the agreement if the state requires it. So I suspect what they're planning on doing is for those providers who have signed, if the state comes with any changes, I suspect they'll just trigger that provision and send an amendment that just automatically applies to the contract. So again, we don't want you to get in that position, and so again, we'd recommend that you hold off on signing until after that approval has been given by the state, you fully understand the contract provisions, and you've asked for some changes that we think are reasonable and in your best interest. Going over some universal things with all the agreements and things that I really think are important and some of the key provisions in here. Obviously, the payment terms. For most of you, the reimbursement amount is going to be the most important thing on your radar screen. When am I going to get paid? And how does that compare to what I used to get paid? When it comes to payment rates, again, I think there's confusion in the provider community depending on the type of provider you are. You should understand how you're going to be reimbursed and ensure that the payment appendix or attachment or schedule of compensation that's attached to the MCO contract details that. Most of them say something like you're going to be paid either the lesser of your charges or 100% of the Medicaid fee schedule. What we're struggling with is not every provider is paid based on a Medicaid fee schedule, and when we've heard IME asked about this, they've sort of admitted, well, in some cases the fee schedule, if you're not paid a fee schedule necessarily, that amount that we set might be the lowest paid provider in the state. That really concerns us because if you're getting more than that, and you're now sending a contract agreeing you're going to get the lesser of your charges or 100% of the Medicaid fee schedule, if that Medicaid fee schedule ends up being whatever the lowest paid provider in your provider type is in the state, that could be quite a bit less than what you're getting now. So make sure you fully understand, here are the services you're providing, and here's what those payment rates are going to be. And if there is this reference to a Medicaid fee schedule, what is the Medicaid fee schedule that they're talking about? Okay, the RFP provides that the current rates are supposed to be paid from January 1st through June 30th, but for most providers, it doesn't say anything about what happens after June 30th, except that they can't pay you any less than the current rates, Medicaid rates. Again, we're not sure what the current Medicaid rates that they're using are, and we would definitely suggest that you require the MCO to put that language that's in the RFP that says they'll never pay you less than the current Medicaid fee schedule. We would like you to ask to have that in there for your protection, just in case the state would ever loosen that requirement. Then contractually it would be in there that they would have to pay you at least whatever that Medicaid fee schedule is. Okay, so again, I would not sign this until this payment, I was very comfortable that I knew what the payment rates were based on, and if it was based on a fee schedule and I'm in a provider reimbursement type that's not paid based on a fee schedule, that I understand what they're talking about and what that fee schedule is that they're using. Another thing to consider with all of these contracts is when you read them, they're going to be very one-sided. They're going to be very pro-MCO. I know that that's annoying, but understand that they have, thousands of providers, and so they have to have the ability to require compliance provider manuals, their policies, their procedures, and their protocols, and typically they reserve the right to change those at any time, which isn't unreasonable. So what we typically say in that regard is because it's very one-sided and because they have the right to require you to comply with all these policies that they can just change with notice to you without your approval or consent, we like to see you be able to get out of the contract without cause if you need to. So if they do implement something that is too costly or too burdensome for you to comply with and you decide you don't want to participate anymore, you're able to trigger that without cause provision. Okay. The other thing to keep in mind is Not all of these MCOs are exclusive to Medicaid in our state, so some of them, many of them are going to contract, are going to have Medicare Advantage plans, are going to have private third-party payer plans. You want to understand whether this contract you're signing is just for participation for Medicaid beneficiaries, or if it also applies to other programs like Medicare Advantage program that they may have, or a private third-party insurance program that they may have. You also want to understand who decides if they want to add programs. So if it says it only applies to Medicaid today, but they add a Medicare Advantage plan, does the agreement just allow them to add that to your contract without your consent? Or can you specifically say, I don't want to participate in the Medicare Advantage plan, I just want to continue my Medicaid participation. So that's something we want to make sure you're fully aware of and talk to the payers about. Okay, some other things to keep in mind is there are some required provisions that the MCOs have to have in there required by the state. So early on I had a lot of people asking, can we extend this 90-day claim submission to 180 days or 120 days? The answer to that is no. The state specifically requires that you submit claims within 90 days if they don't involve another third-party payer. So if there's no coordination of benefits issue, you've got to send your claim in within 90 days. They can't make any changes to that. They're required to have that in there by the state. Another required provision the RFP says is the provider agreements have to require the provider to agree to all applicable terms and conditions in the RFP, the state contract, and any incorporated documents, and then all state and federal laws. Again, you know, that's something that's very reasonable to expect of you that you're going to see in those contracts. You're going to see this provision in there that says that your payments can be suspended if the state determines there's been a credible allegation of fraud and there's an investigation pending. So again, we've had some questions on that language. That's specifically required by the RFP. And then you have to notify the MCOs if there's ownership changes. So you have to notify Medicaid now if there are ownership changes that are, and Medicare, that hasn't changed. What we are seeing, which we'll talk a little bit about later when we go through some of the specific issues in the payer agreements, is that some of them have taken this ownership notification and have it be a requirement before you can change ownership. Well, if you want to sell your business, you don't want to have a payer consent to that before you can sell your business, right? And so we think that's unreasonable. We understand that you need to notify them if ownership changes in the provider, but that notification shouldn't require the pre-approval of the MCO. Obviously, if you have to assign the contract to the new purchaser, they're going to need to approve that. So we would ask that some of that language be massaged. And then because most of you provide home and community-based services, I thought it important to point out that for nursing facilities and home and community-based providers, there are some specific things in the RFP that they say that need to be in those MCO contracts. And for home and community-based providers, those are listed up there. You have to give 30 days advance notice if you're no longer willing or able to provide services to a member, and then cooperate with that member's care coordination and help facilitate a seamless transition. You would be doing that anyway, so we have no qualms about that provision. You have to continue to provide care for 30 days from the date of the notice of transfer. You obviously have to immediately report any deviation from a member's service schedule to their care coordinator. Then there's some reporting requirements, critical incident, and then obviously child-dependent adult abuse reporting, which you're already required to do. Okay, so again, going through some specific provisions in these agreements. I touched on this earlier, but one of the key things, once you've figured out the payment rates and you fully understand that, the next thing I want you to consider is, okay, who is this contract applicable to? Is it just applicable to Medicaid, Hawkeye beneficiaries, or is it applicable to the payer's Medicare Advantage population, or private, third-party or employer-sponsored insurance? Make sure you understand that. I like to see the MCO specifically have to go to you and ask, do you want to be in the Medicare Advantage plan? plan? Do you want to be in the employer-sponsored plan? So you're not required to take them. So that's something that I would ask for. If there's a provision in there that says that they can just add plans with notice to you without your authorization or consent, I would ask that to be revised so that you have the ability to pick and choose which products of that MCO you want to participate in. Okay? The other issue, again, that we talked about is the requirement to comply with their provider manuals, their policies, and their protocols. You know, you're not going to get this out of there. The most you're probably going to get is prior notice of the changes to the provider manuals, the policies, and the protocols. So they let you know if something has changed. You have some time to find that change, understand it, and comply with it. But what I would suggest that you do, if you haven't already done so, is ask to see these policy manuals, policies, and protocols before you sign. Now, we're hearing from some of the MCOs that they don't have, again, because the state contract's not even signed between them and the state, that they don't have those up yet, and that's understandable. But a lot of them operate in other states, and so I would say, can we see the policy manuals, the provider manuals, the policies and protocols that you have in this state or in a different state, or something that would give us an idea of what your requirements are, so we can look to see if what we are currently doing is going to suffice for you. Okay, and again, as I mentioned earlier, we do like to see you have a without cause provision that's not tied to the renewal term, that allows you to trigger that without cause at any time. So if they do make an onerous change in the future, you know, you have the ability to say, you know, the burden of this outweighs any benefit, and so I'm going to terminate my relationship with you. Okay, we touched on this briefly earlier. This is an RFP requirement that claims to be submitted 90 days from the date of service. You know, watch out for a shortened time period. I don't recall that there is a shortened time period in any of these, but you want to make sure you do have the full 90 days and that the contract doesn't require you to submit it earlier. And so you want to make sure you're taking full advantage of that. You may have a longer time period to submit claims if there is a coordination of benefit issue. So if you submit it to Medicare first or employer-sponsored insurance, you get additional time for that. Make sure that you are able to comply with that requirement. Another thing you should understand is you want to know if you're going to be required to submit claims electronically, what software or interface you're going to need to use to do that. So that's a question I would be asking them is, what's it going to take for me to be able to seamlessly submit these claims? Another thing to be aware of in the agreement, and there's no changing this, but it's something that you should know and understand and be able to implement, is your subcontractors have to comply with the MCO agreement's terms. And so if you use a third party to assist you in providing services to Medicaid beneficiaries, you are going to want to ensure that you have a contract with that third party. Hopefully you already do, and you're going to want to ensure that that contract specifically requires them to comply with all the MCO agreement's terms. Okay? Related to this is your referral patterns. The agreements require you to refer only to participating providers unless it's medically contraindicated. And so you want to examine if you're making referrals, who those referrals are going to, reach out to them to say, are you planning on participating with all 4 MCOs, so that you understand if there's someone that's not, how you might have to change those referral patterns for some of your patients. Similarly, if you have any subcontractors that are providing the service, or if you have someone come to provide services to some of your Medicaid patients, you're going to want to make sure that they're participating with the MCOs as well, and so that's something that you want to start checking on. Okay, so all of these agreements have a stated term, which says, you know, the effective date is this agreement is on this date. We anticipate that that would be January 1st of 2016, or the date that you are credentialed by the MCO if later. They have lengthier terms, though, so they'll say, 1 year, 2 years, in some cases I think one says 3 years. We would like to see the term, I don't know how important you feel this is, but I would like to see the term coincide with June 30th instead of December 31st. Because that appears to be when the rates can start being open to negotiation, is June 30th. And so I just think that that's a good time to have that term run. So that's something to ask for. And again, we also recommend that without cause termination provision that can be triggered at any time, not just at renewal of the term. Okay. When it comes to termination provisions, note that if you're one of these providers that I have listed up here, the RFP says that they are not allowed to, they have to allow any of these providers that want to participate with the MCO for the first 2 years, and that they can't be terminated without the prior written consent of the state of Iowa. I would specifically, if you're one of these listed providers, I would specifically ask for that in the contract. One thing that concerns me is how enforceable it is if you were to agree to something, less favorable to you than what's in the state contract or the RFP, whether the MCO would say, well, you had that protection, but you agreed to something else. And so I don't want that to happen to you. And so just to remove any argument to the contrary, I would specifically ask for that language. If I'm one of these provider types up here on the screen, I would specifically ask for that language to be included in the MCO contract, that if I'm one of these provider types, they won't terminate my contract for the first 2 years without the prior written consent of the state of Iowa. To me, that's a very reasonable request. Since it's already in the RFP, they should have no beef with that. Okay. Again, we recommend that you include that without cause that can be triggered at any time. We'd also recommend that you remove any vague for-cause termination provisions. We have seen some in a couple that are pretty vague, and like some that say we don't think you have the required staffing, or we think that you're a danger to patient care. I mean, we would like that fleshed out more, and so we suggest those be deleted. We also think that you should have the ability to terminate in the event the MCO or the payer becomes insolvent or files a petition for bankruptcy or rehabilitation. Again, remember that if these contracts are going to be applicable to more than just Medicaid, it could be a different product line. Yeah, you might have those requirements with the Medicaid beneficiaries to continue to treat them for a period of time, and we might not be concerned that we're not going to get paid on those because it's the state ultimately. But those other products, that's a different story. And so, we think it's completely reasonable for the provider to be able to terminate in the event the MCO or the specific payer becomes insolvent or files that petition for bankruptcy or rehabilitation. The petition for rehabilitation is what we went through with co-opportunity. And so, again, because that is in recent memory, we just think it's important that you be able to get out if it becomes likely that you may not get paid in the future, or at least have the ability to stop accepting new patients of that particular payer who has declared bankruptcy or filed that petition for rehabilitation. Okay, and then you're going to see this provision in the contracts that state that there is a requirement that you continue to provide care for a specific period of time. Post-termination, I believe that's typically 30 days. And again, we think that's reasonable. That's something that the state's requiring. Just note that that's out there. All right, something also to be aware of that might be new and different to you is the I call it the non-solicitation, non-disparagement provision. This is a clause, and the language is fairly similar across all four, that basically prohibits you from discouraging a Medicaid beneficiary from participating in any particular MCO. So let's just, for example, purposes only, say that you don't like dealing with United Healthcare and you would prefer that your Medicaid beneficiaries take WellCare or AmeriGroup because you like dealing with them better, and or you get paid more under those contracts. all of them are going to prohibit you from steering them over to Amerigroup or WellCare and away from United Healthcare. They're going to say you're not going to do anything to interfere with their relationship with the Medicaid beneficiary. You're not going to disparage them. You're not going to encourage them to drop UHC and move someplace else. That's something you want to make sure your staff understands. I get concerned with this provision because, especially with vulnerable populations, they usually have a lot of trust and faith in their providers, and so they may look to you to say, I don't have any idea which MCO I should sign up with, which one should I choose? You're going to have to be very careful in how you respond to that. And so I suspect that this is going to be an issue initially as we're getting Medicaid beneficiaries enrolled, because they are going to be confused, because this is a whole new process for them, because they don't have, a lot of them probably have never heard of any of these groups, and they're probably nervous and worried, and they're probably going to ask providers, you know, for advice. And so you've got to be very, very careful that you do not violate that provision. All right? So make sure the staff that deals with the patients in that capacity understand what they can and can't do in that regard. There are going to be specific record retention requirements in each of these contracts. I tell all my clients, make sure that you're looking at your documentation retention policies and that you're able to comply with the record retention policies on these MCO agreements, because they typically are a little bit longer than what you may already keep your records for. So you may need to revise those policies to have a lengthier retention requirement. Another provision that we have seen in some of the MCO agreements is this non-discrimination provision and the requirement to accept all of the MCO's members and beneficiaries. And I hate this provision and cannot find anywhere in the law or regulation where it was required. I've talked to other attorneys in the state about it. They have, it's their impression that it's also not required. When we have pushed back on this with at least one payer, they continually say it's required by the state. We can't do anything about it. But if you look through the state contract, if you look through the federal and state regulations, there's nothing in here that says that the provider must take every Medicaid beneficiary regardless of their health status. We understand that you can't discriminate based on, obviously, all those protected classes, but you should definitely be able to say, it's going to cost me too much, this patient, you know, I use a nursing facility example a lot. If you have a bariatric patient where you're going to need a lot, have the equipment or the bed or the wheelchair available to be able to care for that patient, you may not want to take that patient. You know, so also, what if the patient's violent? What if it's just not a good fit? You might not want to have to take every Medicaid beneficiary that comes to your doorstep and wants you to provide care. Now, with you being public facilities, with my nonprofit clients, you know, most of the time there's not anything that, you know, that you have in a policy that, you know, says, you know, we don't want to take, you know, more than a certain percentage of Medicaid. And so this might not be that bothersome of a provision to you, but I would want to make sure that, you know, that this provision isn't going to be used to require you to care for a patient that either because of their behavior or because their needs exceed what you believe you have the capacity to provide, or because they're not heeding medical advice and you want to terminate them, that this provision doesn't prohibit you from doing that. One of the things, this is just an opinion and an aside, one of the things that's very frustrating from my perspective is when we do push back on some of this language, we continue to hear from at least one of the MCOs the same response back. There's no ability to change this. This is a legal requirement. When you ask to see, okay, give me the specific citation to the regulation that you think requires this, they cite their regulatory appendix that they drafted. And you go back again and say, what's the regulation that requires this? And they're unable to provide it to you. Yet they continue to insist we just have to have this in there because it's a state regulation. So it is somewhat frustrating when they continue to parrot that back to you. But again, we just continue to push back and say, you know, we understand that the legal requirements, that the the provisions that the feds and the state require of providers should be incorporated in this agreement. But any provision that the MCO has to comply with that doesn't impact providers or provider behavior should not be in there. And I feel like when I see this non-discrimination requirement, that this is a requirement of MCOs when they enroll beneficiaries. They can't discriminate on beneficiaries based on their health needs or status when they enroll them in the plan. To me, they're unfairly extending that to providers. I don't think that requirement exists. I'm open to seeing where they think that requirement is if any of them wants to show it to me, but again, you know, we've not been able to get them to do that. So that's something to keep in mind when you hear them parrot back to you, oh, that's required by the state. Specifically ask to see, okay, what state provision is that you think requires this, or what federal regulation is it that you believe requires this specific language? All of the contracts are going to give the MCO and the state and other government agencies the right to audit you, okay? Absolutely, you should limit those to normal business hours, right? And that's a reasonable request that they should make. You should also require reasonable notice. So if it's reasonable to expect them to contact you to, you know, say in 10, 30 days, we're going to come out and do an audit, please have these records available. What I don't want you to do, though, is contractually agree to give the MCO and the government broader audit rights than they may have legally. And so I always suggest putting in a provision that says, you know, to the extent required by law or authorized by law, you know, the MCO, the state has the right to audit the provider. Okay, as we said at the beginning, all of the contracts state that the MCOs can amend it without your consent if required by law, regulations, or by the state. I believe some of them actually say that they can just amend it unilaterally at any time for any reason. Try to limit it just to, you know, the requirements if they have to amend that agreement for a regulatory reason or the state's requiring it, then they can unilaterally amend it. But I would push back on if they want any other unilateral amendment rights, especially when it comes to payment terms, to just say, if you want to amend it for any other reason, we both have to agree to that amendment. You know, if they think that that puts them in the box, just remind them they have the right to change those provider manuals and policies at any time. Okay? And again, this is another reason why we just want that without cause provision. So if you have that amendment provision, we want ample notice of any unilateral amendments so that you can trigger that without cause provision if you need to. Some of the MCOs specifically state, hey, you're going to comply with all the state contract provisions, and again, to the extent those are applicable to you, I don't see a problem with that, but I would specifically state the MCO has to give you a copy of the state contract provisions that apply to you so you know what they are, or give you a summary of what they are that you're expected to comply with. They all have binding arbitration provisions in them, and so that's the dispute resolution process. So instead of going into the courthouse and filing a breach of contract lawsuit against them, you have to file an arbitration, which just essentially means instead of having a jury decide your dispute, it's going to be an arbitrator that the parties choose. So think of it as a judge, a bench trial, but in a conference room and not in a courthouse, and none of the information is public. And that's very typical in payer agreements, that they're going to want binding arbitration. So they're not going to want the dispute to be public. That's typically why they choose binding arbitration. They usually think it's more advantageous usually to defendants, binding arbitration. It usually is a little bit more costly because you have to pay the arbitrator as opposed to when you file in a court, you have to pay the filing fees and obviously all the legal fees, but you don't have to pay the judge to issue a decision for you. You will be paying the arbitrators, and so it can get quite expensive. you know, I'm comfortable with finding arbitration in these contracts. The one thing I would change in those is I would specifically ask that the venue be in Iowa. You might want it to be held in the county in which you're located, but definitely insist that if there is an arbitration, that it be held in Iowa so that you don't have to haul yourself to California or wherever the MCO is located and has in their contract as to where the arbitration hearing will be held. Another thing we're seeing in some of the MCO agreements is this statement that you're going to comply with, and it has a laundry list of specific laws, and one of them applies to federal contractors. These MCOs are probably federal contractors. You are not, as a provider, a federal contractor. The reason you don't want to be a federal contractor is if you are a federal contractor with over a certain number of employees or with a contract over a certain dollar amount, you have to comply with the affirmative action requirements. That might not sound bad, but it is a round the clock. It's a big job for your HR people because you have to keep those AAPs up to date. You have to run a lot of statistics, and so if you don't have to do that, you don't want to. And so don't contractually agree that you are a federal contractor and you're going to do that, because just participating in the MCO agreement as a participating provider should not make you a federal contractor. Okay, so while the MCO may be a federal contractor, the participating provider should not be. And so, you know, we usually ask if it doesn't already state in the agreement, just something that to the extent these laws are applicable to the provider will comply with, and then you can list those laws. Okay, now I'm just going to spend a little bit of time before we open it to questions, because I suspect there may be a lot of questions and I want to leave plenty of time for that. Some additional issues by payer. So here's some specific issues that I just want to point out that we've seen that are maybe a little bit quirky or that you might not have seen before that we want to point out. AmeriHealth, something for you providers to note is that their appendix requires you to run excluded provider checks on your employees and subcontractors on a monthly basis. I know a lot of you are probably doing it on a quarterly basis. These are the checks you run to make sure that your employees and subcontractors haven't been excluded from participating in federal government healthcare programs like Medicaid and Medicare. You want to make sure if you're not doing a monthly, you start doing a monthly, or you ask for that language to be changed to quarterly or annually. We recommend that you at least do it quarterly. Obviously, monthly is not a bad idea because, again, you would catch someone quicker that way. I just want to make sure that you actually are aware of that obligation and can do it on a monthly basis. AmeriGroup, they have this quirky provision at the end of their indemnification clause that states if a claim is brought by a governmental entity against the plan and the plan seeks indemnification from the provider can't have any direct communication with the governmental entity without the plan's request. We just think that's bizarre, and I think it's overreaching, and we'd recommend that that sentence be removed. Okay? Another AmeriGroup provision is it requires you to forward to AmeriGroup for prior approval all flyers, brochures, marketing materials concerning your payer affiliations that it intends to distribute to the Medicaid population. Again, I think that's overreaching. If you're just referencing we participate in these MCO contracts, I don't see why you need to send all of those to AmeriGroup. I might ask AmeriGroup, what is it you're concerned about, and see if you can get either that provision deleted or at least watered down a bit, because that seems like that's going to be, I don't know why they'd want to have all those come at them either. So that's something to consider removing. Okay, and then UHC has a few additional ones. You'll see there's more up here than the other two. This one I mentioned earlier, they had a provision. I don't know if they've removed that from what they submitted to the state, but they did have a provision early on that said if you wanted to change in ownership, you had to get prior approval of UHC. I don't know any healthcare provider that it's going to run out to all of its third-party payers and get prior approval before it sells its operations. That's just completely unreasonable to me, and I would push back on that. Obviously, there's going to be an anti-assignment clause in those that says you can't assign the contract without the prior approval of the payer. So that should be sufficient. You know, obviously you're going to give them the notification required by the Medicaid provisions. So I don't have any problem having that language in there. But this concept that UHC has to approve before you actually sell, they're not approving the sale. Yeah, if they want to approve the assignment, that's their right. But they can't hold up the sale, or they shouldn't think they have any power to, or that it's reasonable that they should be able to approve your change in ownership. The other two things that are concerning to me is in their Hawkeye, or their TIP appendix. The first one requires you to identify UHC and the state in certain circumstances. We couldn't find that requirement in the RFP or any other regulations that we looked at, so we recommend it be removed, or at least that you ask UHC the question, where is the specific rule that says we have to provide this indemnification? And like I said, I don't remember seeing it in the other contracts, so it makes me think that it's a UHC specific provision and that it may not be required. And again, we couldn't find any requirement. Another thing we don't see as a requirement, and again, I don't feel that this is reasonable, is to add the state of Iowa and UHC as an additional insured or a loss payee on the insurance. Again, you're not going to be running out and putting every payer as an additional insured on your insurance policy or as a loss payee. I would definitely ask that that provision be deleted. And then the last one on WellCare, the thing I would take note of there is they have a provision in their fraud and abuse language where the provider is basically waiving the applicable statute of limitations for fraud claims. I don't like that. I don't want you to agree that there is no statute of limitations and that they can bring a fraud claim at any point in time ever. And so you would want to take that provision out, or at least push back on that particular provision. Okay, so that concludes the formal remarks. Again, as far as timing on this, while there is this time crunch because they still, I think, plan to roll this out on January 1st. At least I haven't heard anything differently. There shouldn't be any rush to sign the contracts, but I can see where they want to get you credentialed. And so if you can start filling out the credentialing paperwork, we have heard that the provider groups are talking to the state to see if there can be one uniform credentialing process for all four. Right now, it's 4 credentialing packets. It's 4 credentialing processes. And I do think that that is going to be one of the more annoying parts of moving to this Medicaid managed care contract is, instead of having the state Medicaid manuals and requirements that you have to follow and being able to reach out to IME if you have a question or an issue or a concern. If Medicaid is the bulk of your business and you are going to be participating with all 4 Medicaid MCOs, you are going to administratively have to make sure you understand all 4 MCOs provider manuals, that you understand how claims are supposed to be submitted for all 4 MCOs. Again, you've got this issue of you have to go through credentialing with all 4 of them. It's just going to be much more annoying and time consuming than it was before. And so you should expect that. So that's just something to keep in mind as you're working through this. So I'm going to stop talking and ask Janine if there are any questions. Occasionally I do get asked, what's the likelihood that any changes will be made to this? I've heard providers say, well, the MCO is telling me, again, no, we can't make any changes. And again, in my experience, that's not always the case. you should be, I mean, again, and some of these things are very reasonable requests to ask for, and we would hope that the MCOs would make those changes. You know, I can see why they would like to have a form provider agreement for the most part, but again, some of these things that we're asking for are very reasonable and not out of line by any means, and shouldn't be things that the state would have to come in and say, you know, we need to have prior approval of that.
Okay. All right. Thanks, Susan. I'm going to go ahead and launch into the questions again with a reminder to everybody. Please use the question feature in your GoToWebinar control panel, and I'll just take them in the order that they were received. So the first one came in just a couple minutes after you began speaking, and that's the big question. How will we know when these contracts are ready for signature?
Very good question. I would continue to monitor, or, you know, sort of any kind of bulletins you get from the state association. I would monitor IME's website about when they're going to be finalized. I don't know that we've heard anything about the timing of that. You know, the MCOs, I can't remember the deadline that the MCOs and the state have to get that state contract signed, or what the anticipated deadline was. But I don't know that you're going to know until IME just comes out and flat out says they've all been approved, right? And so hopefully IME will publicly tell the provider community that. I know there's been, at least I've heard, a lot of frustration about the lack of information and the misinformation that's coming out. And so I guess I would just monitor websites. I would probably say that the Public Health Association should be monitoring that. I try and keep an eye on it. And so hopefully between a lot of different interest groups, we can get the word out to everyone, okay, the state's approved these agreements, they're ready to go.
Okay, thanks, Susan. And I'll just say, this is Janine again for everyone. I attended a really helpful forum that United Way of Central Iowa hosted last Friday here in Des Moines. And I specifically asked that question on behalf of our members. And, you know, should they sign the contracts and just expect amendments? And they said that that they understand people's frustration. This is IME. Understand people's frustrations. They're working as hard as they can to get those contracts reviewed. And so they're really cognizant of it, but it's not ready. And as they said, you know, those contracts can be amended, but I think the input that Susan has provided here today puts you on better footing before you even sign the contract. So let's go on to the next question, and that is, I have a concern regarding reimbursement for birth control pills. Some private plans do not cover the cost under family planning services due to the pharmacy plans only covering being a family planning clinic. We will bill everything under medical, so I'm worried the pills won't be covered. Do you know anything about that, Susan?
I don't. I would suggest you talk to each of the specific MCOs about that to see if there's how that'll be handled, if there's a different way to code it, what that claim submission process is going to be.
Okay. All right. Thank you. Next question. Since there has been in the news, some of the MCO companies have had some legal issues. If we are contracted with a particular company and this happens, does that mean our reimbursement would be suspended?
I don't believe so. I don't know that would impact you as the provider. At least I would hope not. So if there is an issue with one of the MCOs, I suspect that what would happen is the state might terminate that contract, and those Medicaid beneficiaries would be reassigned. But I don't believe that Medicaid would stop paying the providers because of an issue with the MCO.
Okay, thank you.
But again, that might be a good question for IME too to weigh in on. Like, no, we don't have any intention of holding, it could hold up your payment, right? I mean, I can see that happening. But one would hope that they'd continue to pay the claims for the Medicaid beneficiaries.
Okay, great, thank you. Next question, will the state require MCOs to provide addendums once rates are decided for organizations who have already signed provider agreements?
I would hope so. One of my factors in this is, some people, because of that, you've got to sign this by September 14th or whatever the date was, thought they didn't have any choice, and they've been getting quite a bit of pressure from the MCOs to sign. And so if you sign something that says you're going to get this fee schedule, and the state comes out and says, well, it's going to really be this, I would hope that addendum would apply across and I can't imagine why, initially they would pay you guys any differently than what the state is saying that reimbursement should be. But again, for some of you who have negotiating power or have, grown accustomed to a certain rate, and you're agreeing to take a rate lot less than that, you really want to consider that, and maybe you don't want to participate with that particular Medicaid MCO, or maybe you want to go back to them and say this just isn't going to be sufficient. So that's why I think it's really important for those of you not paid on a fee schedule to understand what's that going to be. I mean, how are we going to get paid? What are those reimbursement rates going to look like? And what should that language be in that appendix before you ever sign? But if you have signed, so for those of you who have signed, if something happens to you where you don't get the benefit of whatever the state says as far as payment, again, I can't imagine they would not apply it to you. I suspect that the state would probably say they're required to, but if you have any problems, I'm guessing the state would like to hear about that, and they'd probably go to IME and see if they can help you with that.
Okay, thank you. Next question regarding that is, what if we've already, I'm sorry, let me read it exactly how it is. What will the state require, or will the changes to contracts that you suggest be advocated for on a more universal basis? It seems like each provider having to advocate for the changes isn't nearly as productive. As I am not a lawyer, I don't feel my voice would be very powerful.
Okay, that's a very good question. The problem with sort of any kind of joint negotiation is you have antitrust issues. So you're not allowed to collectively say, AmeriHealth, we're not going to contract with you. None of us are unless you make all these changes. And so don't do that. Don't go to your peers and say, let's group boycott these guys, or let's jointly ask for changes. What I have heard is being done is some statewide associations are contacting them and saying, hey, our providers have concerns, more educational about these provisions. We'd like to see some changes. That doesn't mean that their providers wouldn't sign the contract as is. The associations aren't telling them, hey, don't sign without these provisions in it. And my, comments today are purely, if I'm looking at this contract and you're my client, I'm telling you, here's the areas to be concerned about. Here's the things I would ask for changes. Here's what would make me comfortable. Now, depending on your bargaining position, you might not be able to get those changes made. But in my opinion, if enough people are consistently asking for the same things, then hopefully the MCOs would say, okay, well, we can change this across the board in our provider agreement template for everyone.
Okay, fair enough.
And in talking with other lawyers in the state, I do know other lawyers are pointing out similar things and suggesting similar edits.
Okay. Thank you. That's some collective voice anyways. So there are a couple questions that are essentially the same point as was asked earlier. There are agencies who are on this webinar who've already signed all 4 contracts. What's the process for proceeding to try to make these changes?
So I've had that happen to one of my clients with one of the payers who I won't call out by name, but they just flat out said, we're sorry, you signed it. So if the state requires additional changes, you'll get an amendment, but we're not doing anything. So unfortunately, I think you might be in that bind if you've already signed it. You could, if there's a without cause termination provision, you could try and trigger that and ask to re-sign it. But, you could go to the state, I suppose, and ask them, hey, I signed this not fully knowing I didn't need to sign it by a certain date and that the state contracts weren't approved. But unfortunately, I think that that you could legally be stuck with what you signed and then with whatever amendment that they come out with after the agreements have been finally approved by the state. Nothing's to say that you can't plead with the MCO to say, can we tear this up? And when the new agreement gets finalized, can we just sign that? You could try that too and hope that they would be reasonable and say, okay.
Okay, there are several iterations of that exact question, so clearly that is a pretty strong concern for a lot of the people on the webinar, that there was pressure to get these signed, and now they're out there. So again,
I think I would put pressure on IME. I think I would say, hey, we got misinformation. We feel we were misled. We were told that these were approved. Now you're telling us they're specifically not. We're hearing there are concerns in these contracts. We want out of them. We want you to tell the MCOs to rip them up and give us new ones once they're approved by the state.
Okay, so if everybody's hearing that as a possible course of action is to reach out to IME and express that concern. And again, I expressed that concern at that forum last week, and I know those forums are happening across the state, and I know a number of you have been at those forums as well, so to continue to reiterate that point would be helpful. Here's a tricky question. This is, will the Iowa Department of Public Health be asking the questions or making the requests raised today to all MCOs on behalf of Iowa's local public health agencies? I don't think that
Read that again.
Will the Iowa Department of Public Health ask the questions or make the requests that you've raised today, Susan, make those requests, ask those questions to all MCOs on behalf of Iowa's local public health agencies?
I guess we could ask, but again, I get concerned about, I don't know that there's any, I think it's fine for, an association or Department of Public Health to say, here's the laundry list of concerns our providers have. We want to see these change. We just want to educate you about it and see if they'll make any movement. But we wouldn't want to collectively say our providers aren't going to sign these contracts until those provisions are made, right? So it's more about educating and saying these are the concerns they have, but not collectively negotiating. That's where you have to be careful. Janine, when you were at that conference on Friday, did you hear anything else interesting that we should know?
Yeah, a number of interesting things, and I think, again, I'm probably not sharing anything that several of you who are on the webinar today haven't heard at other venues, but I think it was a mix of providers and consumers, and I know I left that forum thinking as many concerns as I have heard from our provider community within public health, the concerns for the consumers are probably greater. And in terms of communication and understanding this and the letters that are rolling out from IME right now to consumers, so there are a lot of challenges. They're posting those slides and FAQs and such on their website. And again, there's through the portal of our website under Hot Public Health Topics, Medicaid Modernization, you can find some of that. But again, regarding some sort of collective voice back, we can do what you're suggesting, Susan, in terms of submitting some of these questions to the MCOs. But I think another option would be for people to get on the fourth webinar and ask those questions too, so that they're hearing them as a group.
Sure.
I'll move on to, we still have several more questions. And again, remind people, if you have questions, please use that question feature in your GoToWebinar control panel, because we just have a minute left here. One, does Iowa need to get federal approval before contracts are signed with IME and MCOs?
I think they could probably sign it before there's federal approval. I suspect the contract's going to be contingent on getting the federal approval. But yeah, that's something to watch, right? That's got to come in. These state contracts need to get finalized. Now there's challenges to the awards of those contracts. That's legal. Those legal challenges are pending. There's a lot of moving parts, right? And I'm sure it won't shock anybody that, if it's delayed and doesn't roll forward on January 1st. Now, they haven't given any indication that it's going to be delayed, but I don't think it would surprise anyone if it was.
Okay, I'm just flipping through the rest of the questions quickly, and so many of them are regarding, this is great, but we've already signed the contracts, what do we do? So hopefully Susan has, laid out some of what your options are in terms of communicating that. Communicating with IME, I think, sounds like it's a really critical piece of this. Just a lot of the things.
And really understanding, for a lot of you, I'm guessing the primary concern is what are we going to get paid? And so I would really, if you've already signed this contract, I would really be trying to figure out, okay, what am I going to get paid? And is that stated in that appendix? correctly, and if it's not, I'd be asking for a change to that appendix, and I'd be making sure I understand what they're going to pay me, how that varies from what I'm currently getting paid. And that's probably where, because that part is probably the most critical part for all of you, that's where I'd focus my energy on.
Okay, and there are other questions in the vein of, well, this needs to happen, and what about appeals, and what about the federal approval? And I think all of you would probably say, if you've been to any of those IME forums, they are still sticking with that January 1st implementation date. I think it must be a really challenging place to work these days, but that's what they're saying. Another question about, will the slides be available? Yes, they are available right now. If you look in your control panel, they are posted there in the handout section, and you can download them. They are also, or will be, posted to the Iowa Public Health Association webpage, and I'll get to that in just a minute. I have another question for you, Susan. I was told by WellCare that they will not contract for home health services as they already have a national vendor to provide this service. Are you aware of this, and who's their provider?
Oh, I am not aware of that. That's the first I've heard. I don't know who their provider is. That is another thing to keep in mind for some of you. If you've already signed the contracts, if you're not a provider type that they were required to contract with for the first couple of years, you know, don't feel too bad about signing, because you probably wanted to get in and make sure you got in the network. I have not heard that from WellCare, and I have no intel. I just flat out ask them who it is, see if they'll tell you.
Okay. Another last question. I'll make this the last question. Any advice on case management subcontracting?
Okay, so if you're subcontracting case management to a third party, or are you talking about they're going to subcontract case management to you?
Not sure.
Okay.
Later.
If they're subcontracting case management to you, okay, that one. If they're subcontracting case management to you, that's great. I would, again, make sure in that contract that you're not agreeing to something, that you know what the payment rates are going to be, and that you're not agreeing to something that's going to make you a federal contractor. And if you are, that you understand what those federal contractor requirements are. You know, I assume that the contract would look similar, that it's going to be the same type of provider agreement. So I assume all the same things we discussed are going to be issues. The one caveat I have to that is if it's a subcontractor relationship as opposed to just your provider treating a beneficiary and submitting a claim, whether that does rope you into the federal contractor requirements.
Okay, thank you. Susan, I'm going to go ahead and take us out of the webinar now. And I just, on behalf of our association, the Iowa Public Health Association and the Iowa Counties Public Health Association, I'd again like to thank you, Susan, and acknowledge your law firm, the Davis Brown Law Firm, for sharing your time and your expertise with us this morning to address the many questions which clearly Iowa public health and safety net providers have around contracting with Medicaid managed care in Iowa. We really, again, appreciate your time. I would also like to take the opportunity to cue our audience into additional webinars which we are planning for this series. If you missed part 1 in the series, it is posted online. Again, www.iowapha.org. Click on Hot Public Health Topics and then Medicaid Modernization to access that. And again, today's recording and slides will be posted later this afternoon. In the third webinar, we will plan to present a peer sharing of local partners' experience in engaging with the Iowa MCOs to date. What's working, what's not working, just here are some case studies from among our membership and the ICEPA membership. And finally, we will host a webinar in which we will create a venue to bring together local public health departments and managed care organizations to increase awareness and opportunities for collaboration. So stay tuned for announcements regarding these subsequent webinars. And then I'd remind everybody at the conclusion of today's webinar, you'll be directed to a brief evaluation, and we really would appreciate your feedback. It will help inform our planning for the remaining webinars in this series, so please take just a few minutes and do that evaluation for us. And again, an audio recording and slides will be made available on the IPHA website later today. We truly appreciate your participation in this webinar and your interest in Iowa's Medicaid modernization and how public health and safety net providers can engage to support population health in Iowa. Thank you and enjoy your day.